No further ado, I'd like to introduce Dr. Patty McGaughey, who is one of our professors at Montclair State University, and she will be your host.
Hi, everyone. Thanks for the introduction, Brenda, and thanks for inviting me to be part of this exciting webinar today. I am, as Brenda said, an assistant professor at Montclair State. I'm also a certified nurse midwife and have been since 2008. I currently work in a laborist role at Newark Beth Israel Medical Center in New Jersey, which is an urban teaching hospital. So I'm very excited to introduce Dr. Jones. She is a licensed psychologist and professor in the Department of Obstetrics and Gynecology at the University of North Carolina at Chapel Hill. After a decade of directing UNC Horizons, she stepped into a senior advisor role in order to take on several new national and international policy projects. For example, she's the chair of the Global Women's Network for Providers of Women's Substance Use Disorder Treatment and Recovery. Dr. Jones has received continuous National Institutes of Health funding since 1994 and is a top world expert in neonatal abstinence syndrome and opioid-related disorders. She has written more than 350 publications, 17 courses for adult learners on topics of substance use disorder treatment, and multiple books, book chapters, and national and international guidelines on the topic of caring for women, as well as children with substance use problems, including those published by SAMHSA, the United Nations, and the World Health Organization. So without further ado, I turn this over to Dr. Jones.
Thank you so much, Dr. McGaughey. I really appreciate it. And thank you to Montclair for everyone's support and to SAMHSA, of course, for bringing us all together. I am going to just make myself smaller. I hope. There we go. All right. Let's go ahead and step through these slides. So we have a couple of learning objectives for everyone today. So hopefully by the end of this presentation and answering people's questions, you will be now familiar and able to identify some important common elements for what makes effective care for pregnant and parenting women who have substance use disorders and their children. We're going to take a look at what is the latest data on maternal, fetal, and neonatal safety and efficacy when we are talking about medications to treat opioid use disorders. So things like methadone, buprenorphine, and naltrexone. If you are not already familiar with those, I will introduce you to those and how they work. And then finally, by the end of this, you will be able to name some things that you can do, practitioners, providers, clinicians can do to support a mom who has a substance use disorder, as well as her child that has been prenatally exposed to different substances. I don't have any disclosures to share for this. And I do want to start out by honoring the patients that I have the honor and joy of working with, that many of you will also get to work with every day. And I'd like to just give a couple of quotes. These are quotes from women who have recently been with us at the UNC Horizons program, which is a comprehensive care program to treat pregnant and parenting women and their children. And so the way I get these quotes is that I lead a group every Tuesday. I was just in group today. And so oftentimes I will ask our women, I'm giving a talk to important people, what maybe providers, clinicians, what do you want them to know? And so I am going to read a couple of things that they shared with me to share with you. The first one comes from Jessica, and she says, "Please stop treating me like I am my worst mistake. I already do that to myself every day. I need you to see the hope of who I am and who I can be." Another quote comes from a patient named Danny. "Ask me to my face, not looking at your screen, what happened to me, and be ready to hear it. Don't flinch. Don't change the subject. If you can't sit with what has happened to me, how do I trust I can sit and survive it?" And finally, a quote from Amy. "Recovery asks me to imagine a future worth being clean for. You can help me build that picture, or you can just manage my addiction. Anyone can write a script. Not everyone can help me want to build a life of recovery." So I share those quotes from women so that we remember the why we are here. We are here to help moms who have substance use disorders and help their children. I think it's also important when we talk about this topic that we ground to make sure that we level set so everybody knows what a substance use disorder is. And so we know from our Diagnostic and Statistical 5 manual that there are 11 signs that make up how severe a substance use disorder is. Pre 2013, we diagnosed substance use as either abuse, a milder form of addiction, or dependence, the more severe form. But that was really confusing because of the pharmacological issues with being physically dependent on a substance, but not necessarily having an addiction or a use disorder because of that substance. And so here I put in the 4 quadrants just to ground us in what we're talking about. So there are really only 2 actual physiological ways that contribute to a substance use disorder. One is tolerance. And we know that from people take a certain amount of a substance, be it an alcohol, a benzodiazepine, an opiate, you name it, a cocaine. They take that first amount, they get a certain effect. When they take that same amount again, they get less of an effect. And so what we see is folks have to increase the amount that they're taking just to get an effect, or they have to change the route in which they're taking, maybe from orally to injectable. So tolerance is one of the signs of substance use disorder. A second one is withdrawal. So when people take a substance, they get a certain effect. It might make them feel good. It might slow everything down like opiates. And then when they no longer have that, they get the opposite effect, which is when, if you work with people that take opiates, you will often hear them say, I feel like I'm going through the worst flu of my life with that withdrawal. Those are really our only 2 physiological effects. Everything else, the other 9, are behaviors. That impaired control. I wake up in the morning and I'm only going to have 1 drink and I end up having 10. I say I'm going to quit today and I just can't. I say I'm only going to, use at a certain period of time, but I can't. I end up spending all day looking for drug, using drug, recovering from drug. That impaired control. We can't control how we're using our substance. And I think, particularly for women, this impaired social functioning and relationships is so key with substance use disorder diagnoses and how women get identified in our systems of care. So often we have role obligations, being a mother, a wife, a caregiver, an aunt, a cousin, all these different things, being an employee. And so it's oftentimes, I think, harder for women to hide their substance use disorder because of these role obligations than it is for our male counterparts. So again, when that substance is impairing people from being able to fulfill their role obligations, to be the person that they want to be, when there's a lot of conflict in those relationships, those are other indications of a substance use disorder. And then finally, hazardous use, things like using a drug and getting behind the wheel of a motor vehicle, or using the substance even though we know that we have hepatitis C. So putting ourselves in harm's way, choosing the substance or using the substance over a health condition. So I hope that that helps ground us all so we're speaking the same language. Also, other key points is that substance use disorder is a pediatric or developmental illness. When you look across the data from the United States for decades, we've seen that the average age of substance use initiation for women in this country is about 15 years of age. So less than an adult. So it's our job to make sure that we are talking to our young ones, our adolescents, and normalizing the conversation, helping them understand, and getting them help when they need it. Also, too, it is very rare to find women who come into treatment that start using substances when they're pregnant. Oftentimes, women are using substances and then become pregnant. And finally, there's a fundamental difference between substance use versus a use disorder, right? So that's our 11 signs. If you have a mild use disorder, you have 2 of those 11 signs. But also, there's a difference between that and prenatal exposure, because we can have prenatal exposure to our medications like our methadone and our buprenorphine, for which we have a medical prescription, for which folks are doing the right thing, following their doctor's guidance. That's still exposure. It can lead to a neonatal withdrawal syndrome, or babies being in withdrawal. And we know that that is very treatable and should not be considered a safety risk for mother or for the child. Other things that I think are important to talk about to level set this conversation is dopamine. So we know that dopamine is that motivating chemical that keeps us around, as is oxytocin, helps us feel connected and go through life in meaningful relationships. When we don't have enough dopamine or we're having a really bad day, we have less dopamine floating around in our brain. If you're having an average day, like listening to a webinar like this, you probably have about 50 nanograms per deciliter of dopamine in your brain. If you have the most amazing day, it's going to top out at about 94 nanograms per deciliter. When people take drugs, it can overwhelm our dopamine, and we can have over 1,000 nanograms per deciliter. But that isn't sustainable. And the women that I see that come into Horizons often have very low levels of dopamine, around maybe even 10 nanograms per deciliter. When you have low dopamine, you get intense craving. Your brain kind of tricks itself into thinking it needs that substance to get that dopamine to survive. It also makes it really hard to get out of bed in the morning to be able to fulfill those role obligations that we have to care for our children, to be that nurturing person. And so I share that for us to have empathy and understanding and patience with the patients that we are serving. I also want to share that oftentimes we have amazing empathy and compassion for people that don't have access to water or access to food. I'm going to give you some relative craving size data in our brain. So there have been studies that have been done where people have voluntarily undergone 3 days without water. They get then put into a brain scanner, and water is dropped on their feet. They listen to sounds of water, and they see where the brain lights up. And the brain lights up with a relative craving size of about a baseball in their brain. When a different experiment, but similar in vein, 5 days of food. People elected to go 5 days without food. I hope they're paying patients a lot of money for these studies because it's a really hard thing to do. And then after 5 days, they put them in the scanner again, and they waft their favorite flavor of food in the scanner. They might even give them food, have them chew it out, but not swallow it. They have to spit it out. And that relative size of craving in the brain, 5 days without food, is the size of a basketball. Now, when we think about, I will often ask if we're doing this live and in person, how big do you think that the craving is if you have somebody that has not had their drugs of addiction for 10 days? Oftentimes I'll get, oh, the size of a beach ball. I've also heard the sun. Let me tell you that it is in between those two things. It is about the relative size of a baseball field in your brain. And I love these pictures because I think it just helps us understand the power of addiction as well as our opportunity to make interventions work for the people that we are serving. So now that we've level set about substance use disorders and craving, I want to move now to our more maternal part of our presentation, and just to recognize the incredible importance of overdose. We know that across the United States, well, these are data just from North Carolina, my home state. We know that when we look at many different states across the United States, that overdose deaths are the #1 driver of maternal mortality. Oftentimes they get lumped in with mental health conditions. I know the CDC had worked to get that changed. And so I just want to hold space that this is an opportunity. Every single one of these women that have died, it could have been prevented. That they're touching our hospital systems, they're touching our drug treatment systems, and so that's an opportunity that we can have for change. We also know that the WHO has done different types of analyses looking at for every death, that's 31 in North Carolina, there are 310 near misses, estimated near misses, and the WHO has actually estimated even greater, that there could be even 620 near misses for every 31 deaths. So looking at the deaths is incredibly important, but also looking at those near misses is equally important too for intervention. I am sure that many of you have heard and are very well aware of the changing drug supply. We have all sorts of things that have escalated, particularly since COVID. There is our opioid data lab, the UNC Street Drug Analysis Lab. go on their website, check out, they have, I think, samples from all of our states where you can see sort of what's in your drug supply, because we know that our drug supply has become more dangerous and also more diverse. So we've got not just fentanyl as one of the opioids, but all things like medetomidine you might have heard of, or perhaps some of the nitazines that you've heard of. And I think an important thing is that people don't always know what they're taking. We've had women, these are direct quotes from women at Horizons. I had no idea. I thought I was just taking methamphetamine. I did not know that it was mixed with fentanyl, and her urine was coming up fentanyl positive. That allows a conversation and a set of treatments that can be provided. And for another woman said that there's no more heroin on the streets. We can't get heroin. It's all going to be fentanyl. And so I need now, because that fentanyl is so harsh, I need to cut that and offset it with a stimulant or cocaine. So again, point of that slide, know what's in your community, the types of substances, and what are the risks so that you can help empower people to have safer lives and to be able to get the treatment that they need. These are data, our national data from 2017 in the blue bar to 2023 and the dark blue bars. And what I will invite you to notice about this, these are self-reported data among pregnant women who reported substance use. Our fully licit substance, our fully legal substances, our tobacco and our alcohol, easiest to access, and the ones that are most commonly used or endorsed being used by pregnant women. And when we look at our illicit substance, well, a lot of times we hear a lot of media attention around fentanyl use. That actually makes up a much smaller proportion, important but smaller proportion overall of the illicit drugs that are being used. Right now, in these data, cannabis or our high potency THC products are in that illicit drug category, which makes up the bulk of that self report. So we know that prenatal effects to have alcohol and other substances can have different prenatal effects. I encourage you to not think about, oh, a pregnant woman used this drug, therefore we are going to get outcome Y. It is way more complex than that, and we're going to talk about why that is. So here are some of the things when we're thinking about alcohol, why we see different effects from really no effects to fetal alcohol effects to full-blown fetal alcohol spectrum disorder, or FAS. So it depends on how often someone is using, the quantity that is being consumed when during pregnancy. There's a lot of work around genetics and other maternal factors, being of an older age, having less nutritional positive status, and all the other environmental pieces can help either mitigate or exacerbate the effects that we see intermixed with prenatal exposure to alcohol. So it's not just a drug equaling an effect, it's a drug plus all of these other things that can help us understand the effects that we're seeing and where to have interventions. Other things that we know about untreated prenatal exposure to alcohol, we know that it is a risk factor for miscarriage and stillbirth, as you can see. Again, are older women drinking high concentrations of alcohol with high blood alcohol levels during first trimester. We can get structural defects or anomalies. We can have neurodevelopmental outcomes that need intervention. When we think about tobacco use, our other fully legal substance in the United States, oftentimes this gets overlooked. And so thinking about how that impacts a mom's ability to have nutrients absorbed, we can have a greater risk for placental abruption or placenta previa or preterm labor. For the fetus, we can have growth restriction. There's less oxygen getting to the fetus. And then for the children, there can be relationships, again, depending on how the quantity of tobacco and other maternal other hello thank you and other types of child effects. We can have cognitive delays or learning disabilities as just a few examples. So in terms of cannabis, I call it high potency THC because I think even the cannabis that's out there that is being smoked has been changed to be more highly concentrated than it was when a lot of the original long-term studies were done looking at prenatal exposure to cannabis. And so I will not read this slide for you, but you can see the references. There are a lot of things that we are beginning to identify as related to high potency THC. Again, keeping in mind that other environmental factors are important. And here are a few of those other influences that can influence long-term development of children. So, socioeconomic things like air pollution, lead exposure, climate change, food insecurity, adverse toxic stress. All of those things we know can play a role in epigenetics, which is how genes turn on and turn off. Our inner uterine environment with maternal immune activation, diet quality, mood disorders, medication exposure, all of those things can in some way interact with the child's developmental outcomes. Our caregiving environment is incredibly important, as is the child's own internal development, physical and development themselves, what's going on. And then also too, there's interest now in what is the paternal impact in terms through sperm contributions in terms of child developmental outcomes. So all of these things, again, it's not just the drug equals effect Y, right? It's the substance plus all these different things that can either mitigate or exacerbate different outcomes that we see. This is just a slide to remind me that what I already said earlier, which is that the potency of THC has been going up in the different types of cannabis products that are available in the United States. And so we will see what our long-term outcomes are going to tell us with the HBCD study that is, believe it's still ongoing now. So stay tuned for more data on outcomes. When we think about pregnant women who are using substances or have a substance use disorder, we know that fear of the medical system can really keep them out of care. Ever since I think the earliest is, in the very early 70s through all the way through 2025, I can identify papers that talk about fear of the loss of custody, fear of maybe the police being called because someone has been using substances during pregnancy, fear about stigma and shame, the having to make the decision of, do I try and parent the best I can with the substance use disorder that I'm managing, or do I leave my child or children and go to a residential treatment program to begin a treatment process? So oftentimes we don't have enough women and children's programs for people to be able to feel fully comfortable in their treatment experience, so they might not go. Other barriers: lack of childcare, lack of transportation, all of those things we need to think about as we are caring for this patient population. Another important piece is around what I've heard from people with living experience. How you see me dictates how you treat me. There was just a woman in group the other week who talked about, when the doctor walked in to deliver her, that doctor made a very unkind face towards her when he found out that she was a person who was using substances during her pregnancy. So how you treat me affects me and affects my sense of safety and trust. And I'm only going to go to places I feel safe, and I will actively avoid those unsafe places, even if it means waiting until the last minute to come in because I don't feel safe in my healthcare system. Why is that important? Because there is a beautiful opportunity. We've had data literally from the 70s up until 2024 that show that when we can get pregnant patients into treatment and keep them in that prenatal care, even if they don't stop using their substances, we can improve birth outcomes. And you can see that as an example on this slide. So if you look at a comparison of pregnant women and their children that had no substance use disorder versus those that got treated for their substance use disorder versus those that didn't get treatment for their substance use disorder, didn't have prenatal care, you can see that those outcomes are not as optimal as those that had that treated SUD. So our job is to keep our patients coming back and keep them engaged in care, because every opportunity that we are with them is an opportunity for a conversation and an opportunity for change. So sometimes we'll hear, oh my gosh, I don't even know where to start, right? So these are some clinical pearls for starting that conversation. First and foremost, you are not alone. If you are interested in working with pregnant patients that have substance use disorders, there are so many resources. There are just villages of people that want to help. The ASAM, American Society for Addiction Medicine, for example, has a women and addiction group. There's the PCSS that has great resources. They have a mentoring program that you can kind of phone a friend. There's Choices International. There's a nonprofit doing this work. There's Doing Right by Birth. There's lots of different places. I could go on and on. So uh, feel free to reach out. I'm glad to connect you. So what can we do? The first thing we want to do is we want to be curious, not judgmental, but just start with some open-ended questions. And then also, before you start those questions, make sure that you have information ready to share, accurate info on brochures, on QR codes that your patients can follow up with later if they are interested. So an example, especially with cannabis, help me understand what the role that cannabis is playing in your life today. Oftentimes I'll hear from pregnant patients, oh, I'm using it because I can't sleep, or I'm using it to treat my nausea. The really great thing is that we have other options, and it doesn't have to just be, or it doesn't have to be cannabis at all. We can give other things, behavioral interventions, as well as medications that can be prescribed. We also want to have a dialogue. So, recognizing I am here to support you, I want to know what helps you because I know that you are the expert in your life. When you are ready, I'd like your permission to give you some information and wait for that permission. Make sure that they say yes before you give that information. And certainly acknowledging their perspective because they hear a lot of information. And you can certainly understand from all of the information in the media, I can understand why you might think that, cannabis is natural or is safe. Again, we're going to share some additional information with you for you to make your own decisions. And then again, that providing that education, you don't have to change someone's mind. Your job is to perhaps introduce some doubt and have them get curious about different information so that they can make the changes that they feel best in their lives. Other points for engagement is that we want to be curious and not corrective. It is not, what have you done to your baby? It's, help me understand what's going on in your life. Help me understand um, what you what you need to be the best mom for your baby. Let our patients guide us. And I think it's so important to know what matters to them, not what is the matter with them, right? What matters to them? What would they like from this visit today? We want to make the first step be really easy. Having flexible hours, thinking about their transportation. What were the barriers to get there? What's the barrier to come back? So, making sure that you have those resources and ideas to share with them is important. Partnering with trust anchors, such as leveraging the trust that they have, um, building bridges and not using that baby as a punitive event, and then importantly, nothing about me without me. So transparency, we are not going to say anything about them or put anything in their chart without them knowing. So what can you look for in good programs? Moving on to our second learning objective. So we have known what to do since 1993. The second treatment improvement protocol that was ever published by SAMHSA was about women's services. I invite you to look at that because that is still just as relevant today, those parts of programmatic services. Here are some other services that can also be really good things to look for in a good, safe model of care, that it's integrating co-occurring treatment. We know half of our patients have anxiety, mood disorders, so making sure that we're treating both, not just one or the other. Making sure that we have an empowerment-based approach. We're talking about parenting, family support. What is the next step through treatment is also really important. So they're not scrambling at the end for a discharge, but we've got a plan, a strategy in place to help people step through the services that they need. Here are a couple of different evidence-based types of treatments or therapies that have been studied in pregnant and parenting women. So I invite you, if you're not familiar with any one of these, my personal favorite is dialectical behavioral therapy. One of the patients that we had a number of years ago said, you know, Dr. Jones, I came in with a pocket full of pills, and today I am leaving with a pocket full of DBT skills. And so they're super practical and can be so helpful for our patients. What are some flags? So what we've talked about the good things to look for. Let's talk about the things we want to avoid. When programs have shaming or punitive practices, when there's no focus on that aftercare, when they have super rigid or unrealistic expectations, when they don't have qualified staff, if they are not accredited by an accrediting body, that is something to want to learn more about. Um, Having high costs with no transparency, poor facilities conditions, use your gut when you are looking at places. Other things that are warning signs, if they take away the cell phone, that is denying communication rights without a clear policy or rationale is very concerning. Any kind of unauthorized posting on social media. I have seen programs where they take patients and their children's pictures and put them up on Facebook without their permission. That is not right. So isolating, not allowing, or removing medications from people also concerns. So, what can you do if you're considering a program for someone? Is ask questions, right? Tell me about your license. Tell me how you're accredited. What kind of treatments do you offer? Are they evidence based? What are the patient's rights? How do patients complain? What is that process? Read the reviews, especially all the different places, to see what are the main complaints and then what are the main kind of rave reviews. And then also, yeah, again, trust your gut. Now I want to talk about our medications to treat opioid use disorder. There are three. The methadone and the different buprenorphine products are the ones that we know most about during pregnancy. So our methadone is a full mu opioid agonist. What that means is you have opioid receptors in your brain. The medication comes in, locks onto the receptor, and fully turns it on. This means for methadone, the more methadone that a person is given, the more effect it can have. Obviously, there are things like tolerance that come into play, but we know we need to adjust the dose at the right time for the patient. Don't adjust it too quickly, although the age of fentanyl has changed things, so we can have conversations about that. But just remember that it's a full mu opioid agonist. More medication you get, the more effect you can get, which can include some sedation, some heart rate suppression. But people do build up tolerance to this medication, so they need oftentimes more medication over time. Buprenorphine is a partial mu opioid agonist. So opioid receptors comes, locks on the receptor, turns it halfway on, basically. There's a ceiling to it. So you get a little bit of heart rate suppression, a little bit of respiratory suppression, but the more you give, you don't get more of an effect. That is not to say that everybody should only have 16 milligrams. We know in the day of fentanyl, patients often need more medication than they needed before in this area of high potency opioids. Buprenorphine, also because of its ceiling effect, is really, really hard to overdose on. In fact, the overdose that we see with buprenorphine are involved with other types of substances like benzodiazepines when they are both injected in a non-therapeutic way. And then there's naltrexone, which is that antagonist. So we have our opioid receptors, medication comes on, locks on the receptor, doesn't turn it on at all. And so it blocks the effects of opiates, but people don't necessarily really like to take this medication because you get a little bit of nausea, maybe a little bit of headache. So it's not for everybody, which is why they have created an injectable form so that people don't have to remember to take it every day. Why is it important to take medication? Because we have studies that showed that people that did not receive the medication, there were actually 4 people that died in this study when they compared it to buprenorphine. So we know that our opioid agonist medications like methadone and buprenorphine can be protected of overdose. And this study was actually stopped early because of how the safety profile and advantage of buprenorphine was over nothing. I'm often asked, well, why should we keep people on medication? Why can't we just medically assisted withdraw them or detox them? We know that when we look across the non-pregnant literature, it doesn't work very well for non-pregnant patients, and it's unrealistic to expect it to work particularly well for pregnant patients. And you can see here the data vary widely. And so what we've really come to the conclusion of is that there is an increased risk of a return to use, which then we're really setting that patient back. So it is not recommended. It is much better to to have our patients have voice and choice around the medications that they would like to take to protect them from overdose and to help them reach their potential. These are guidelines that were published in 2018. And there are 16 different fact sheets that I can invite you to look at, everywhere from prenatal care all the way through postpartum care. This affirms that we want to avoid doing that medication-assisted withdrawal and that methadone and buprenorphine are the safest medications to treat opioid use disorder, and that breastfeeding is also recommended for our patients who are taking their methadone and their buprenorphine as prescribed. So here you can see very similar advantages to these medications. There tends to be an advantage for methadone in terms of retention and treatment, and there's an advantage for buprenorphine in terms of babies having less neonatal abstinence syndrome that needs a medication to treat it. I would say that both medications are safe, relatively safe and efficacious for mom, for fetus, and for child later on. There are also, every medication has disadvantages, and you can see those disadvantages here on that slide. But again, the risks generally are outweighed by the dangers of doing nothing. We know that untreated opioid use disorder during pregnancy is related to concerns for both mom, fetus, and for baby. We're also asked, well, we know that buprenorphine alone is safe and effective and methadone, but what about the combination product of buprenorphine plus naloxone, which the long-acting injectables or the sublingual often have naloxone in them to help minimize diversion, people not taking them as prescribed or selling their medications. And here you can see in a summary that basically we don't see differences in outcomes between the buprenorphine alone and buprenorphine in combination with naloxone. So we've got more choice for patients to be able to use. We also know that in this era of xylazine, fentanyl, nitazenes, all the things, that it is a little trickier sometimes to initiate patients on to the medication that's right for them. But there are great protocols out there. It's a lots of evolving science right now. And we know that for both methadone and for buprenorphine, that split dosing, taking half in the morning, half in the evening, can help stabilize mom and help stabilize the fetus. And so we know that we can minimize side effects and that we really want to do individualized dosing, best for the person. This is hot off the press. It was just published in JAMA in March 16th. And what this shows is a trial of that was randomized between sublingual buprenorphine, so that combination under the tongue versus injection. And what we found was that both had really great outcomes, and that in terms of negative urine drug tests, there was a statistical advantage for the injectable to have higher negative urines that were free of opioids during pregnancy, similar birth outcomes. So again, yet another option for patients. We also need to think about not just medication, but medication plus behavioral intervention, peer support specialists, case management, therapy, and as you can see here, there are some different types of therapy, cognitive behavioral therapy, and motivational interviewing you will see throughout, regardless of the substance. And when we think about prenatal opioid exposure, opioid use disorder during pregnancy, as I've alluded to before, neonatal abstinence syndrome, which is like the general constellation of signs of withdrawals that babies have after they have been delivered. The umbilical cord is cut and there is no longer exposure to opiates. So NAS is the big category. NOWS is specifically reserved for babies that have only been prenatally exposed to opiates. And it is incredibly rare that I see babies that have only been exposed just to opiates. It's opiates plus tobacco or alcohol, benzodiazepines, etc. It's important for us to remember that babies cannot be, by definition, born addicted. Substance use disorder is continuing to use substances in spite of negative life consequences. And we know that when we can keep moms and babies together, we can increase that upward spiral of resilience. Mom is the medicine. We know rooming in, encouraging breastfeeding, and using symptom-based NAS treatment, so not having to put babies on a medication to treat their withdrawal, maintaining them and weaning them. We don't have to do that. There's some great data that just came out, and I think it was in JAMA again, like yesterday or the day before, that shows that symptom-based, so giving little bits of medication only when baby needs it, is an effective and safe way to treat babies' withdrawal. Another paradigm shift that has often happened is moved away from a scoring system, and now we are using Eat, Sleep, and Console. And we find that using that system gets babies out of the hospital faster, and they don't have a worse adverse events or return to hospitalization. Oftentimes, we also see that drug testing gets misinterpreted or it's overly used to make child protective service decisions. And so I could give a whole talk on this, but I will just suffice it to say that we need to be really careful when we are interpreting opioid drug toxicology tests. We know there are data that show that someone's last use of fentanyl can stay in and be detected up to over 290 days later. We have also had women have child protective service case reports opened on them because of the fentanyl that was used in the epidural when they were in labor and delivery. So we have to use this as one tool and be very careful in our interpretation. Moving on from pregnancy to postpartum, the fourth trimester is that last 12 weeks after the birth of a baby, and we know it takes time for mom's body to return to a pre-pregnancy state. Probably takes more than 12 weeks, but 12 weeks is that really important time to look for postpartum depression to ensure that there are supports around mom. The World Health Organization recommends routine postpartum care 3 days, 1 to 2 weeks, and 6 weeks. So ideally, we're going to have 4 touches on mom before that 6 weeks, and to make sure that it is individualized. This is a little bit more. I invite you to look at the American breastfeeding protocols that are there. There's a little QR code to it that gives a lot of information and guidance around drug use and breastfeeding and how to help moms and babies. And we know that skin to skin contact, rooming in, and being positive with mom. This is such a vulnerable time for mom. And so, how do we tell her what she's doing well? And also talk about her guilt and shame and stigma. And let's leave that at the door because it's not doing anybody any good. I would be remiss if I did not talk about fathers in the newborn period. And so dads have superpowers too. They can play such an important role in identifying postpartum depression or other mood disorders, helping with feeding, even if mom is breastfeeding, helping her change diapers, helping rest, understanding that sex might be different in this postpartum period, helping them understand how to bond with baby and nurture baby and talk to baby. All, again, great opportunities for father's involvement and intervention. And then what can you do? You have all the control and power over the words that you use. And so inviting people to think about person first, being a person with a substance use disorder, also thinking about urine drug tests being positive or negative rather than clean or dirty. We very rarely use those words to talk about any other type of medical test. And so I invite us to normalize tests for drugs by positive or negative. Other things that you can do, making sure that you are being honest and transparent and having compassionately hard conversations with people. We can't control all the different systems, our hospital systems, our welfare systems, but what we can do is we can tell patients what we know. We can encourage them to ask questions. We can encourage them to seek out information. And before we ask questions to our patients, be it on written form or verbal form, we need to ask ourselves, why are we asking that question? What are we going to do with that information? And how will it be used and how will it be available to others? We want to include patients in our decisions, point out those strengths. As you heard from the quote in the beginning, you can't tell me anything worse than I already have told myself every single day. I need you to see the hope of who I am and who I can be. Making sure you know the resources in your area. I have literally heard of patients that go to the emergency department who have a substance use disorder, want buprenorphine, and are told, I can't help you. I don't know where to find it. We wouldn't do that with any other medical condition. Can you imagine if someone was having a heart attack or a hypertensive crash and we said, we don't know how to help you? We need to empower all of our hospitals and all of our clinicians and providers to know where the resources are. We want to tell stories of recovery and success. People recover every single day. There are millions of people that are living in recovery. And so making sure that we're helping to tell those stories where possible, making sure that people have access to naloxone, reminding ourselves that naloxone or Narcan can be used for everybody, including pregnant patients. and then advocating for that compassionate care of moms and babies staying together. So, I am now at the end of time, and I wanted to leave a good amount of time for questions. So, just to finish this up, I hope from the presentation that I have given that you are now able to identify some of those good elements of effective care. You know, to look at the SAMHSA tip, you know, to look for evidence based practices, looking for accreditation, and then also the flip side of what are some of those red flags to look at. You are now well versed, up to date in the latest data that we have on treating prenatal opioid use disorder with methadone. There are different forms of buprenorphine, and we have just a little bit of data on naltrexone compared to those other two. But our recommendation is when patients are already taking their naltrexone to have that individualized, tailored conversation. Document your clinical decision making around risks and benefits, and that where possible, we want to keep our patients on naltrexone if it's working well for them, because the data we have good birth outcomes on it. But again, it's a small amount of data compared to methadone and buprenorphine. And finally, to name those different actions that you can take. You have power and control over your language. You have power and control of what you share with your patients. Nothing about me without me is our mantra. And with that, I'm going to share the webinar survey. You can let us know how you did, what you thought of this information today. And finally, before we turn it over to questions, just remind everyone that helping one person might not change that whole world, but it certainly could change the world for that one person. Thank you.
All right. Thank you so much, Dr. Jones. I feel like you have almost a midwifery approach to substance use treatment, and that makes me very excited. So I'd like to welcome all of our guests to please put your questions in the chat, and I'm going to try to kind of look through them and see if we can pick out a couple of great questions to end this, hour that we've had learning and expanding and thinking about our own biases and how to put them in the right perspective. So please go ahead and type your questions in the chat. Directly to me, if it gives you the option of who to put, Patty McGaughey. And hopefully while people are getting those questions put in, I might just start with one, Dr. Jones, if you don't mind.
Absolutely.
So pregnancy and giving birth, and especially the ways people give birth, can cause a lot of pain. Do you have any advice for providers and healthcare workers to try to minimize the risk for substance use disorder as a result of the pain medication that we are prescribing in pregnancy and in the postpartum period?
Oh, what a great, thank you so much. And I love that you said that I had a midwifery approach. That's fantastic. I've never been told that before, but and it makes so much sense. Yes, so I think, ACOG and others have done a really good job advancing the field around pain management during pregnancy, labor, and delivery and the postpartum. I mean, years ago, I will say that we used to have patients that would come to us with an opioid use disorder, and some of them would say, I developed my opioid use disorder because I was given 30 Oxycontin after I had a vaginal delivery and I started using them. I don't hear that anymore. I think that our protocols around, we can still give opioids, and I think that that's a really important point. Sometimes I hear that people are really afraid to give opioid agonist pain medication to our pregnant patients that have an opioid use disorder. And that, in some ways, can almost be worse because we know when we have unmanaged, untreated pain, that can set someone up for having a return to use. So I think the answer is let's ask about pain, let's manage it. Don't be frightened to avoid opioids, short-term opioids, 3, 5, 7 days at most of opioid agonists. We know when patients come in for labor and delivery, we can certainly use epidurals, we can use the blocks, we can use the different types of pain management techniques that are available. And we've even had for some of our cesarean patients, VCA pumps. So the other thing that I'll hear is like, oh, well, if they're already taking methadone or buprenorphine, like all their opioid receptors are filled, they won't even feel that opioid medication. That we have data to show that that is not the case, that we can use opioid agonists on top of their medications. So we want to make sure we're maintaining people in the hospital on the dose of their opioid use disorder medication, their methadone or their buprenorphine. And then we need to be able to manage their pain on top of that. Those medications are not going to treat their pain or somehow substitute for pain medication. I hope that's helpful.
Yeah, that's very helpful. Thank you. Some of our guests would like to know about studies with populations from women of color and how we should think about kind of that intersection of higher risk groups, perhaps in substance use disorder.
Oh, what a very important question. We know that people of color, regardless of education or socioeconomic status, are more likely to die, to have maternal mortality. And we know that when we look by race, that we can see differences in the general data in terms of women of color are more likely to have the hypertensive or cardiac issues that lead to the mortality, whereas again, a gross generalization, what our collective data tell us is that white women are more likely to die of an overdose. That is not to say that we should ignore cardiac issues in white women or ignore overdose issues in women of color. So my experience and my understanding of listening to people of color is that they're not heard in healthcare. I sat on the maternal mortality review committee for North Carolina and did a deep dive into other maternal mortality review committees. And so often our women of color come in. You can see it in the hospital that they complained of hypertension. They had swollen ankles. They complained of bleeding, and they weren't believed. They weren't heard. They were turned away. And so there is just this incredibly urgent, important opportunity for our hospitals to have a more equitable and sustainable and ethical approach to listening to patients. And again, I think there are like wonderful societies and organizations from both grassroots and the national level that are really helping elevate this and work on it. And so thank you so much for that question.
Right. Another question from a qualitative researcher in the field. She finds that many perinatal women's entry points with child welfare is due to neonatal abstinence syndrome, even when the mothers are being treated. So, in what ways can healthcare providers still support prenatal women's treatment options without risking child welfare notification, which can be very disruptive and punitive?
Yeah, super incredibly important question. And so I think, first of all, for every provider that is out there to look at your hospital policy. Oftentimes, hospital policies are doing more than what our federal regulations, federal guidance are asking us to do. So, on an individual level, we can have great influence and important conversations with our risk management, with the lawyers at hospitals, and understanding that there are actually some lawsuits in the other direction too, because there have been punitive approaches to women who were identified as using substances, and they really didn't. They weren't. That misclassification of urine drug testing is one of those things. I think having accurate, transparent conversations with patients for them to be able to make their own decision. So and also having information and conversations with Child Protective Services. One of the things that we've done where I live is we have a great relationship with Child Protective Services. We will give them in services when they ask about what is trauma, what is methadone, what is buprenorphine. We know that how states interpret the captive care legislation that came down in 2016 with what is, a drug affected newborn, what is withdrawal, that nowhere in there did it explicitly say that methadone or buprenorphine are, those are those medications. Either they didn't carve them out, but they also didn't specifically call them out. And so being able to talk with the decision makers and the Child Protective Service implementers about what is an SUD and how it is managed, and that these medications, I mean, we have more data on these medications than we have for most other medications in pregnancy. So ifwhenhow.org is a great resource. I would say Movement for Family Power is another resource that's been doing a lot of work in this area. Pregnancy Justice is also another organization. Um, I'm sure there are more. I'm blanking on the rest of them, but hopefully that gives you a couple of, and so you can look up your state. How your state is interpreting the Captive legislation. I believe in the if, when, how you can do that. If I'm wrong about that, I'm happy to get you the right resource, but that's a good place to start.
Great, thank you. And I've just been asked to request if you could stop sharing so the participants
Sure.
can see you better, Dr. Jones.
Okay.
And I might just throw out one final question here. We have a lot of educators, I think, on the call today. And while you were talking about the success stories of patients and kind of sharing success stories back to patients, I was thinking about our learners in the healthcare workforce and wondering if there's a nice way to share success stories of treatments to our students, because I think that might be a way to help reduce stigma or help them see the hope in their work as future healthcare workers.
Oh, yeah, I love that. I think, we've done that for our nursing teams, because so often, and like our ED teams, because so often our in hospital clinicians and practitioners see people at their most vulnerable, at their worst, and they don't get to see the long-term outcomes. So we've done little video vignettes for folks. We've actually done in services where we've brought some patients back and bring with us. So including that patient voice is just so essential in everything that we do. It's the why we're here, right? So I think every opportunity, considering newsletters, considering having videos that we have obviously the release of the patient to be able to share their story. So many of our patients are really excited to share their stories, and show that their child is doing well, and that they're, that everyone's developing as they want to.
Great. Thank you so much. I think I'll turn it back over to Brenda Marshall for our closing remarks.
I was just thinking perhaps we can ask everyone to put their videos on so they have an opportunity to thank Dr. Jones. This was really an amazing presentation. It's wonderful. We're going to have you back and have you here for a longer period of time. This was great. I want to let everyone who is watching know that we have at Montclair State University our DNP for psychiatric nurse practitioners, the DNP for family nurse practitioners. We are bringing about a DNP that is going to be special for educators, people who want to go into education, and of course, our Masters in Education, as well as many other programs. And the D2R, Diagnosis to Recovery. And on June 24th, we will be having our full day conference. And we hope that everyone will join us. Maybe Isabella could put a link to that form in the chat. And we thank everyone, and especially you, Dr. Jones, and you, Dr. McGaughey, for bringing this to life for all of us. Thank you so much.